Welcome back to Best Guessistan. This is the place where we explore rupture, that thing that split your life into before and after, what ruptures reveal about systems failures, and some surprising routes to repair and survival on the other side. Today, we'll be talking about a rupture that happens inside the body but affects everything outside: brain injury. I'm Wendy Lurrie. This is a rupture I know intimately. When your brain changes, your life changes. Your pace, your capacity, your abilities, your sense of self, your cognition, your mood, all of it recalibrates, often without your consent. And while the world expects recovery to be linear and predictable and fast, the brain operates on entirely different physics. In this episode, we'll look at the symptoms, but we'll look underneath the symptoms at the science. What's happening inside an injured brain? Why do some people recover quickly while others don't? Why does one brain injury predispose you to more brain injuries? And how people can build lives in the long tail of nonlinear recovery. Today, we shift from metaphor to medicine to understand not just what rupture feels like, but what creates it and what complicates it. Let's get started. Dr. Merati is a board-certified neurologist and neuro-ophthalmologist based here in New York City. She completed medical school at Kansas City University of Medicine and Biosciences. Then she completed her residency in neurology at Michigan State University. Then she completed a fellowship in neuro-ophthalmology at NYU. And I just have to say, on a personal note, I count myself so fortunate to have met Dr. Merati when I did. She is my go-to expert on all things medical having to do with my TBI and the person I trust the most. And every time we talk, I learn so much more. So I know how much better informed we will all be by the end of this conversation. Welcome, Dr. Merati. Welcome to
Thanks
Best
so much.
Guessistan.
Thanks so much. So kind of you to mention that. And you're one of my dear patients. It's just so nice to be here. So thank you for the invite.
Thank you for joining me and for helping to educate everyone. So let's just start at the beginning. Could you introduce yourself, talk a little bit about the work you do?
Absolutely. Yeah. So my name is Melody Merati. I work here in New York City. I see a lot of headache medicine. I also see a lot of neuro-ophthalmology. I primarily practice in both Brooklyn and Manhattan and Midtown. And I see a lot of patients who struggle with not only concussions, but traumatic brain injuries. And I think it's something that we need to focus more on because these patients are really struggling and they have limited abilities to even get access to care. So I see a lot, I treat a lot, and I'm happy to be here to talk more about it.
And later on in the conversation, I'm going to give you what we call the magic whiteboard, which lets you design the system you think we need. Because obviously there's more to be done. So we will get to that, but I'm really glad you brought that up to start with. Can we start with like defining terms? TBI, concussion, mild, moderate. I came across acquired brain injury. Could you just help us understand what all these words mean?
Yeah, absolutely. So, traumatic brain injury is an injury to the brain from some sort of impact. So, whether that be from, a motor vehicle accident, somebody having a whiplash injury, whether or not that be from, a jolt to the head from some, force, it's some sort of force to the brain that causes injury and lasting side effects of that injury. And so, we really classify traumatic brain injuries based on whether or not they were a mild TBI, moderate TBI, or severe TBI. So really understanding and talking to patients about how did this happen? What was the force of impact? Where did it hit? Where was the force of impact? Was it the front of the head, sides of the head? Was it the back of the head? Really gives me a good understanding of what patients might suffer from later on in their course of the disease process, as well as treatment, how it may go. But it's also really important. I think this is a big problem that we have is putting everyone into a box of saying, oh, you have a mild TBI. You should recover by this time, right? Because sometimes that's not the case. And I think that's where a lot of the frustration lies. But we do have a rubric that we kind of determine based on, someone's verbal response, eye opening, or in their motor response to give us a good idea of whether or not this was a mild or moderate or, more of a severe impact to the brain. We also use imaging, right? So oftentimes when someone comes to us after they have, some sort of brain imagery, some sort of brain injury, we like to get brain imaging to verify, do they have a skull fracture there? Is this more of a severe case that we're dealing with? Or is there blood in the brain from their injury? And so using imaging modalities can really help us understand how severe the impact was. And then, of course, the neurologic exam, right? So every time someone comes in, we do a dedicated neurologic exam to assess someone's, function after they had some sort of TBI. So we take a look at their mental status, their concentration, their attention, their recall. All of these things can help us understand what the concussion or TBI has caused, and if it has caused severe neurologic deficits, that's when we get concerned.
Well, I wanted to ask you actually to talk about some of the different impacts and maybe it has to do with where the hit was. I mean, I know for me it was vestibular and vision primarily, but I know there are other types. So if you could just talk about the different kinds of impacts, that would be great.
Yeah, so impacts from TBI, just like you had stated, is can include things like people have really severe vertigo, they suffer from a lot of dizziness, and oftentimes it may not be the typical room spinning dizziness that we think about in our ear pathologies, right? So dizziness can be very difficult to describe for patients who have TBI. They may feel like they're on a boat. They may feel just imbalanced when they're walking, but oftentimes it can be just, as subtle as, I just don't feel right. And so, dizziness is um, a prominent, effect of a TBI. One of the most common things that we do see associated with TBI are headaches. So headaches, I would say the majority of patients that come to see me after a TBI, they suffer from headaches. And whether or not they're, cervicogenic, whether or not they're tension type or whether or not their, semiology seems like migraine, headaches play a huge impact in those patients' quality of life and their day-to-day routine after their TBI. Another thing, patients can have nausea associated. They can have fatigue. They can have memory loss. They can have problems with their, cognition. And so, we see all of these associated impacts from a TBI and breaking them down into specifics of, okay, we're going to start by treating each thing at the at each thing separately, right? Because I don't want to treat you with one medication because one medication is not going to treat everything. And so dividing them into categories can be super helpful for not only patients but providers, because it can be really overwhelming for TBI patients to talk about their disease because they have all of these symptoms and they don't know where to start. And so the impact is can be you know huge.
Well, and there's something really interesting in what you mentioned that someone's saying dizziness. What are the limitations of language when it comes to patients trying to describe what they're feeling?
Yeah. So right after TBIs, some patients will get impaired cognition, and so talking about dizziness, prior to a TBI may be very easy for someone to discuss with a clinician. But after a TBI, it can be difficult for patients to express their words, and so um, the clinician has to understand that they may not be able to tell you exactly what they're feeling, but they're dizzy. Dizziness is a broad terminology. So, dizziness might mean lightheadedness, and lightheadedness to a clinician you might think about as a blood pressure issue, right? Because we know TBI patients have a dysautonomia. They can have dysautonomia associated with their TBI. So their blood pressure can drop when they stand. And so, does dizziness actually mean lightheadedness? Does dizziness actually mean vertigo? So vertigo, we think about, do they have a BPPV, or do they have something that we call triple PD? So there's all these different types of terminology that patients can use, but it's going to be difficult for them if they have cognition that's impaired after TBI. And so really trying to be patient and understanding that it may take longer for a patient to, respond to questions that you may have. And it may it's gonna be a, "Okay, let's rule out that it is not a blood pressure issue, that it's not little crystals in the inner ear that have mislodged from the traumatic brain injury." So ruling things out is gonna be super important for those patients.
That's really helpful. I wanted to sort of talk about like the underlying biology, like what is going on when a brain is injured. I want to get to irritability, which we will, but first is like what's actually happening to the brain when a TBI is happening.
Yeah, so that's a very complex, question, right? Because there are there's a lot that's going on in the brain that, we certainly can't fit into one talk. But, one of the things that can happen is you get damage to mitochondria in the brain. And so when there's damage to mitochondria in the brain, this can contribute to axonal problems. And axons of the brain, they transmit communication between neurons. You also get hyperexcitability in the brain after a traumatic brain injury. So, oftentimes, if you hear a clinician say your brain is really hypersensitive to your surroundings, this often also happens with migraine. And so, you get this depolarization in the brain from a traumatic brain injury. And so, when you have hypersensitization of the brain, your brain is going to be affected by things who someone who doesn't have a TBI won't be affected by. So, fast moving cars may really bother you, bright lights are going to bother you. Being on a computer screen for too long, that's going to bother your brain. And so all of these things can be um, a problem for someone who may not have had these issues in the past, but they all of a sudden become relevant after a TBI because the brain is very sensitive from the depolarization, from the damage to the mitochondria, and from the axonal damage. We often can see diffuse axonal injury to the brain after a severe TBI. And sometimes those patients have such a severe TBI that they're hospitalized in the neuro ICU. And, again, imaging plays a huge role in determining, okay, this is a very severe head injury because we actually see diffuse axonal injury on imaging. So,
I did have a question about how much you can see on imaging.
mhm.
I know that can be challenging. I mean, I know
Yeah.
with me, they looked for a bleed or a skull
Mhm.
fracture, but short of that, it was kind of hard to read anything.
Yeah. And so that's also plays a huge role in, the the problems that can happen if you've had, let's say, a mild or moderate TBI and there's nothing on the imaging, right? And so oftentimes those patients are really frustrated because they're like, why am I experiencing all these symptoms? There's nothing there. And it's often a more, you feel invisible in a way because you're like, I'm having these headaches, I'm having this dizziness. Why is nothing showing up on imaging? And so I think it's really important to understand that that may be the case, that we scan your brain with multiple modalities and we don't find anything, but you're still symptomatic, and that is very valid, valid, symptoms, and it shouldn't be discouraged to the patient. We know this, and it's very important for both patient and clinician to understand that your symptoms are not invisible. We hear you, we understand you, and we got to treat your symptoms.
I'm asking this for me personally, in addition to just general knowledge. Like I have the sensory issues you talk about that I didn't have before. Loud noises. I'm a New Yorker all my life. Loud noises, fast moving cars, even fast moving things on the TV. I still have to do this and this, and it's 3.5 years. Do these things? I mean, like I said, the therapies to help some of the deficits have helped, but something like that, like the sensory disturbances, do those wax and wane? Are they permanent?
Yeah, so yeah, great question because they are going to wax and wane. And so, you know this yourself, you're going to have good and bad days, and that includes good and bad days with your sensory symptoms too. There are medications to dampen the response that you do have, and some of those medications that we use are migraine medications to dampen the response. But they don't fix it, right? And so they're only really temporary measures. And those sensory symptoms might persist. They could persist for a very, very, very long time. It really just depends on the person. And so that's what I was mentioning. It's hard to put everyone into a box with a bow tie on it and tie it in a nice little bow because everyone doesn't fit into that box. And so um, even though someone may have had more of a mild TBI, their sensory symptoms might persist, for years. And it's just about managing the symptoms of it. Unfortunately, I wish we had some kind of this is going to stop it, for good, but we can even use injections to help dampen the responses, but it may not completely fix it.
So a lot of people who have a concussion or a TBI, right, recover quickly, like in 2 weeks.
Hmm.
What are the things we know about the rest of us, those of us in the 10 to 30% who don't recover? Like what makes someone more likely to have this as a longer term problem than someone?
So, age has something to do with it. So, the the literature does state that if you're younger, you're more likely to be able to recover from a TBI um, compared to if you're of older age. It may take your brain longer to recover. And then, of course, y- how what's your when you initially present after a TBI, what are your associated symptoms? Are your associated symptoms just headache, or are they headache, nausea, vomiting, fatigue, dizziness, memory loss, cognitive issues? So are they a you know large, wide variety of symptoms that you can't just take a day off of work and rest and recover from everything, right? So it also depends on like the impact of the force, how many associated symptoms you have, and some people are just more predisposed to having more hypersensitivity to the brain than others. I think it's something that we need to look more into, but
It's interesting. Does history of migraine make you more susceptible to this longer term problem?
yeah, so we know there is a genetic component to migraines. So migraines can run in families. And so, migraines, what happens is there can be a cortical spreading depression too. So, if you already have a history of migraines, then you probably will have, a little bit harder time responding to after a TBI than someone who has a clean slate, no history of migraines, never had dizziness, and they don't have any neurologic, issues. They don't have history of seizures. They never had a brain bleed in the past. They don't have a meningioma or they don't have a mass or tumor that's causing
Mm.
issues in the brain to begin with. So, um, and that also goes along with the history of patients who have meningitis. So inflammation of the brain from like a CNS infection. They already have that baseline history of having, you know, damage to the brain from something or inflammation to the brain from something. So something like a TBI may tilt those patients over the
Mm.
opposite way compared to recovering faster.
So you said something really interesting before about where the hit, well, where the impact was affects what part of the brain. So for me, my impact was here, right? I got hit by a
Mhm,
hatchback. So if I
mhm,
got hit here, and that's
mhm,
also not where I ever feel the pain. All the pain I have is back here. It's here.
mhm.
What's going on?
Yeah, so, you know, what happens is you can get this when you get this like sheer force to the brain, things shift, things move a little bit, right? So, people who get hit in the back of the head, they may hit, the occipital area or the neck, the cervical region, and so they are, they may have predominantly cervicogenic headaches. People who hit the front, our eyes are right there, and so it really just depends on not only where you're hit, but also the force of impact plays a huge role too. Regardless, we would treat you with medications on, but determining what type of medications differs between the type of impact to the brain. And so, you didn't have a skull fracture. If you had a skull fracture, we'd be looking closely at, where the skull fracture is. Does it impact the eyes, right? Is the optic nerve involved? And so all of these things give us an idea of, where the force of impact was. And we have to look closely at those regions to make sure that, specific parts of the brain are looks okay.
That makes sense. Okay, I want
Hmm.
to get to irritability because you've brought that up to me and I've read about it. And I would just like you to talk about this whole idea of brain irritability, what it means, how it manifests, the whole shit.
Yeah, so brain irritability is can cause a lot of problems for people. Not only what we touched about for, it can cause headaches, but it could also contribute to, mood dysfunction, cognitive slowing, um, so irritability to the brain, again, we also see from seizure and we also see from migraines, but it's everything is really connected. And so that's why oftentimes we use these anti-seizure medications and anti-migraine medications to treat TBI patients is because they help to calm down the irritability of the brain. We can also use migraine medications to help with sensitivity, hypersensitivity to patients having photophobia or, they feel really sensitive to light. And so it is this sensitivity that we're um, treating of the brain, which is can be often really complex. And, you have to talk about risk versus benefit with these medications, right? Are the side effects worth it? And people who have been on multiple medications, they may not think that a side effect of, you know, extra fatigue when they're already experiencing fatigue, it may not be worth it for them. So it's really an individualized approach.
The mood governance you mentioned, and the emotional governance are definitely things I've experienced
Yeah.
that were kind of surprising, and, for things that you never had to think about, and all of a sudden, like, you need new strategies to govern mood and govern emotion.
Yeah. Yeah, and I think, getting help from colleagues is super important in that aspect, and, talking with therapists and psychiatrists is gonna also be really imperative for a patient's recovery process because, again, if you put everyone into a box and they don't recover in 3 months, 6 months, 9 months, they often become depressed from that, right? And so their mood changes, and when patients' mood changes, they're less likely to recover, because they don't have energy to do that. They don't have energy to go to their PT/OT sessions, and so, it's kind of a plays effect on multiple different aspects, but the psychological, impact can really affect a patient's recovery very much so.
Well, you're right, because there's frustration, but there's also
Yeah,
guilt, right? Because
yeah,
everyone's told, like, you should recover on this timeline, and shame that you can't, muscle through it, and it just takes a very difficult situation and just adds layers and layers and layers of difficulty on top of it.
yeah, and I think oftentimes patients, do feel a lot of guilt about bringing it up to their clinician of, when a clinician asks them, "Oh, how are your headaches? Are you still experiencing headaches?" And if they are still experiencing headaches, they may downplay that, right? Because they don't want to seem they don't want to seem like they're not recovering because they should be, or they've been told that they should recover. And so I think that's also it's also really important to feel really comfortable with your clinician and talking about these really important things because otherwise if you downplay your symptoms then it's going to be hard for us to know how to treat you too. And
Sure.
so
But it's hard not to feel like you're a
yeah,
failure when everyone is
yeah.
expecting you to recover on a specific timeline.
Yeah, absolutely. And I think the biggest thing is that, asking for help is not a weakness, it's actually a strength. And I think helping patients to understand that, especially really high functioning patients who, were never had to deal with any of these symptoms and then all of a sudden have to deal with these symptoms, it's hard for them to ask for help, right? Because they've never had to. Um, but just helping that, patient provider relationship and making them feel more comfortable to talk about it is a big plays a big.
Assuming they can find the clinician
Mhm.
has the right questions to ask, there's enough time in an
Yeah.
appointment, there are just so many barriers.
Yeah, that's right.
Um, so you talked about some of the medications. You mentioned the anti-seizure, and a lot of them are migraine meds. Is there anything coming up in research, in drug development that is promising, that you're excited about?
So, the anti-CGRP monoclonal antibodies are, it's been a game changer for the migraine world because of these, CGRP medications, which can really help with not only migraines, but also can help with headaches secondary to TBI. And so, these have been really a game changer for my patients. And then, of course, there are injections that can really help. So, occipital nerve blocks, trigger point injections, Botox can also help with photophobia. So, there are things that have been developed that we didn't have before for TBI, and I'm sure there are things that are coming out in the works. I haven't personally heard of anything yet, but that doesn't mean that's not coming around.
I did a quick
Um,
Google the other day just to see what was in the drug pipeline,
yeah,
and there wasn't a ton,
yeah,
honestly. They just
yeah, and I agree. I think there needs to be more research about this, and it would be fantastic if there was one drug that not or symptomatically helped everything, all the symptoms of TBI. We don't have that yet, but maybe in the future that would be
maybe,
something. Yeah,
maybe.
maybe.
I mean, there's so many things about this particular condition that are really, really hard. One of it is just, like, how unrelatable it is to anyone who hasn't had it, right?
Yeah,
But another thing that comes up a lot is the advice overload, right?
yeah,
And you've got patients who are dealing with all of the issues that came from the TBI, the sensory issues, the irritability, the cognitive, the mood, all of that stuff, and then everyone is throwing stuff at them. "Have you tried this supplement? And I just read about this thing, and my aunt got better after this." How do you counsel patients on how to sort of sift through and the influencers, right? You have the whole influencer community who wants to solve all these problems. How do you help patients, like, navigate through this kind of morass of maybe some of this advice is good and some of this is just not a good use of anybody's time?
yeah. So, not only do patients, get advice about, TBI, post TBI, how to deal with it. But, we see that in multiple other conditions too, right? And so there's a lot of really great information online, but there's also a lot of not so great advice or information online. And so always thinking about evidence-based medicine is super important. And, talking with, if you have a trusted, clinician or provider that you see, talking about, hey, this is what I read about that I should consider this, these vitamins to help. Is this true? And I will encounter that a lot where patients do their own research, which is phenomenal. I think having more, doing your own research, I actually encourage patients to, hey, read about this and let me know if this is something that you're interested in proceeding with, because I think you would be a good candidate for something like this. And that can be, medications that we talk about, injections, nerve blocks, Botox. Talk to family and friends about this, because I think, having more insight about what you're going to be getting, right, can give you more power in the long run for your own health, right? But I think there is a lot of misinformation online, and we see that, and I do see that a lot, especially with neuro-ophthalmologic problems that patients will come in with, and headache management too. But just understanding that, we have a lot of evidence-based medicine and a lot of research out there that helps us to guide the treatment plan. And so talking with a trusted provider should be, after the initial internet search, bringing it to your clinician to see if something that you should proceed with.
Hmm. I mean, one of the saddest places on the internet I've ever found is the TBI subreddit.
Yeah.
And people just show up. I mean, I see it every day and they say, diagnose me. Is
Yeah.
this normal? What should I be
Yeah.
doing? And they're asking a community of non clinicians.
Yeah, and I think that goes along with limited access to care, right? It's just, I think neurology in general is hard to access for patients, and so oftentimes they may resort to the internet to help, which is kind of brings me to a point of, we need more neurologists out there, because the wait times for neurologists can be very long and extensive, and we know earlier treatment after TBI improves recovery time, and so I think there also is a big part of that is access to physicians that can help. And so they may resort to going to the internet instead.
Well, so I'm going to bring the magic whiteboard up because that's where we are right now. Access is a problem, awareness is a problem, right? Education is a problem. You have the magic whiteboard, there are no restrictions. You can just fix whatever parts of the system you think are most in need of being fixed. Hiring, bringing on more neurologists, training more, that's one. What else would you do?
Yeah, so I think one of the biggest things that could really improve a patient's recovery would be having an advocate for patients, their own advocate, to help them throughout the recovery process. So that advocate can help them with appointments and getting them access to, specific neurologists or, headache specialists or neuro-ophthalmologists, for convergence or whatever that may be. Having an advocate there to go to their appointments with them so they don't forget what the doctor was talking about, writing down information, having a calendar for the patient, because oftentimes they have cognition problems, so they can't recall what the discussions were. Advocating for those patients, and having an advocate for each patient, I think would be a game changer, because a lot of patients don't have that, and so they're either relying on themselves or they're here and they don't have family close by, and so it's really tough for those patients to navigate the process. Tough for patients to navigate the process without a TBI, let alone having a TBI after. And so oftentimes those patients are like, "What did we discuss? What was the main, points, and how should I take this medication?" And so a big thing to improve them would be advocating for them. Also, access to care like we talked about, but you know, is there a world where we can have, like, a walk-in clinic for those TBI patients where they don't have to wait another 3 months for their appointment, but they can walk into, an appointment and talk about their symptoms, that have been progressive for that day, and, changing the treatment plan, right? And so I think, having that capability, because we do know that symptoms do change on a day-to-day basis. It's not a linear process, and, TBI patients know this. It's not linear. It's good and bad days, and sometimes symptoms may plateau, but having that accessibility to care is super important.
Think of that the way I the way I frame I don't know if it's gonna be a good day or a bad day is this idea of living with a feral animal.
Yeah,
And some days the animal behaves and just stays in the corner and leaves you alone and you can get on with most of your day. And some days the feral animal is in charge and you don't have control of anything. And that's actually how and you don't know what it's gonna be day to day. And the
yeah,
symptoms aren't settled. I thought they would be settled, but they still seem to be changing.
yeah,
That's the
yeah.
normal course. That's
Yeah, it's not unexpected. And so you oftentimes will have those days where things are great and you can walk outside and you can see a subway pass by you or a fast moving car. You can be on the train and you're asymptomatic and you're feeling great. And then you go home and you wake up the next day and you're like, what is going on? I had such a great day or week and now I'm back to two steps behind where I was. And so it's really not unexpected. And I think that's also another hard thing for patients to understand is they think they're backpedaling, but oftentimes we know that's what happens is you have these good day or weeks, and then it could regress a little bit.
making it all the more frustrating and all the more challenging.
Yeah,
Um, so I'm sure with a lot of patients come to you because they think you can fix this, right?
yeah,
And sometimes you can, and that's great. When it can't be fixed and they need to make the shift from, "I wanna fix this," to, "I need to live with this." Ha for me personally, that was, as you know, a very difficult shift. It took me several years before I was willing to acknowledge that I couldn't do what I used to do, that I couldn't work the way I used to do, and I felt like a failure. And
yeah.
I felt like every accommodation that was offered to me was a sign of, like, my own weakness. So, like, how can the system better support people making that transition to, "This is something I just now have to live with"?
So I think it's a really important talk. It's an important point to talk about because that is a huge game changer for patients when they make that realization, and it has to come within. It has to come from the patient, right? And so, um, you know, I can't tell you that this is gonna be your new normal. I can tell you, maybe you haven't been responding to medications as much, the therapies are not as effective for you. I think it's time we bring up the discussion, but I can't it has to be something that the patient understands and is ready to talk about because I think it is a huge step in the recovery, you know, process to say I think I'm gonna have to deal with these symptoms, and it's just something that I'm gonna have to manage rather than I'm gonna go back to what I was before TBI. It's a very difficult conversation, and it's very delicate conversation. But I actually think when patients do come to that realization, it's kind of like a clarity for them.
Nice.
It I had a patient who did feel so much better after she came to the realization that this is her new normal, and she had told me that it's okay because she is, putting all of her, pain into and putting it into artwork or whatever it may be, and so, um, getting to that point can be very difficult, but I do think it patients, um gives patients the clarity that they need to move forward, in a way, you know, as odd as that may sound.
It actually doesn't sound odd because I
Yeah.
experienced it myself. It was
Yeah.
very difficult to get there. I remember telling you that I was going to finally apply for disability, and you said, "I've been waiting. What's taken you so long?" And what took me so long was accepting that this was where I was and that the answer to the question, "Could I go back to the person I was before?" was probably no. Is that a question a lot of people ask?
Yeah, it's a very common question of when am I gonna be able to go back to doing, the job that I was doing, or when am I gonna be able to go back to, reading 16 books and, people who, were, editors, when am I gonna go back to not seeing double vision and all these things, right? And so it's, a challenging conversation, but it comes from the patient and right, and so when they have that realization and they come to you, that's when we have the discussion, but as a clinician, it's hard for us to start that conversation when if someone's not ready because there may be other things we can try if the patient is willing, but the patient may come to the realization that I don't think, at this juncture that things may are gonna help as much as before.
And it must be hard for you as a clinician. I know how deeply you care about your patients when there are patients you just can't help beyond a certain point. I mean, that must be a lot of weight to carry too.
Yeah, I mean, it's very difficult, but, obviously the patients are going through it, right? And so I can't even imagine the day-to-day, life that they must have and the struggles that they must encounter with all of their associated symptoms that they have from the TBI. Our job is just to, be there for patients and, you know, as much as we can, and so, we do everything we can to help with, you know, the the therapies and the medications and the vision, getting people prism glasses for the double vision at near and helping with their photophobia and all these symptoms, but there it's a hard thing for us too, and understanding that we can't we may not be able to help you, 100% get back to where you were, but we can do everything we can to help your symptoms
Which is a lot. I mean, helping with
recover.
the
Yeah.
symptoms is a lot. Um,
Yeah.
so do the non-damaged parts of the brain compensate for the damaged parts of the brain? Like new neural pathways. Can you talk about like how that works?
Yeah, and I think that goes along, with the, notion that younger people, they may be more likely to recover from a TBI than someone who's older, and, maybe that is related to the atrophy that's happens when we do get older from the natural aging process, so the shrinkage of the brain, and so less likely to, recover some of those axons. Like what we were talking about before, somebody who's had injury to the brain before, or they've had multiple concussions, um, you know, whether or not that be from sports related injuries, concussions from, anything else, they're going to have a harder time to recover than someone who didn't have those multiple, hits to the head. So, the just like from stroke where you have, decreased blood flow to the brain, which causes injury to the brain, younger patients um, are more likely to recover faster from a stroke than someone who's a lot older.
Mhm.
Let's say someone who's in their 70s or 80s are going to recover have a more difficult time recovering from a stroke than younger. So it has the same notion of those connections, build faster than someone who's in the older range.
That makes sense. I mean,
Mhm.
I know I felt like parts of like I knew how my brain worked before. I was ridiculously aware of how my brain worked before. It doesn't work the same way now. I feel it working now because it feels like I'm using different parts of it than I used to because I have to rely on the non-damaged parts.
Yeah.
And I can actually like it's almost like I can hear the gears.
Yeah.
So
Yeah.
it's just like a super like I don't know if it's the same way that like a one sense compensates for another when one is weakened, but
Yeah, you're using, different parts of your brain to help compensate. You know, we see this, when patients have, vision loss associated with a stroke. Some patients can recover their vision from a stroke. After a certain amount of time, they can recover from, a posterior cerebral artery stroke to a certain degree. So yeah, there are connections that are made, and I'm sure you are very hypersensitive to those connections when they are working. And I think that goes along with the sensory symptoms that you have after a concussion, where you're very aware of um, you know, your own sensitivities, but also, how you feel on a day to day basis. So
um well one of the things that I noticed was the acceleration of my age-related vision deterioration. Well, that's a lot of words in that phrase, but I know it normally comes on slowly, but for me, it in the course of 6 months, I went from being able to see musical notation on a screen without glasses, because 'cause I've never worn glasses, to not being able to really see anything on a screen without glasses, and it happened so quickly.
yeah.
Can you help me understand that?
Yeah, so sometimes patients can have couple different things after a concussion or head injury to the brain. One of those things, that we commonly see after concussion is problems with near tasks. So oftentimes patients will have eye strain, eye pain when they're reading or when they're on the computer, or when they're doing anything up close that causes problems from them. And so not only eye pain, eye strain but double vision. They may see images that are, side by side. And so that can result from a convergence insufficiency. So convergence insufficiency, we commonly know happens post concussion. And so what we typically do for those patients is we recommend pencil push-ups, which is something that you can do, at home. Um, and there's also great YouTube videos online to kind of help you guide, those pencil push-ups, but they can strengthen those convergence muscles after concussion to help with the eye pain and eye strain. And we know this objectively because we measure it. So we measure your convergence in office, and then after pencil push-ups or vision therapy, which is a big part of the recovery process, the convergence improves. So objectively and subjectively, patients do feel a difference with their near tasks. Um, some patients, can also have double vision, which is not from a convergence problem, which may be from what we call cranial nerve 4 palsy after a
I was just
concussion.
going to ask you about fourth
Yeah.
nerve palsy. That was my next question. Yes.
Yeah. So they see two images, and instead of being side by side or oblique, or they're, in the relationship to another, each other, they're in a different position. And so, cranial nerve fourth palsies can also have to happen after concussion, and so something as simple as prism glasses can help with those cranial nerve four palsies. And so, referring to an optometrist to help with ground in prisms can be super impactful for those patients to bring the images together and to avoid the eye strain, eye pain, and headaches that can result from cranial nerve four palsies. So um, going along with that is you get the photophobia, right? So it's very sensitive to light after a concussion, and so using blue light blockers can be really helpful for patients. So you can actually get them ground into your glasses to help with computer work or with phone work if you still are doing that after your concussion. And so,
Also,
uh,
dark mode.
mhm,
Dark mode is magic.
dark mode. Yep, a lot of computer settings can help with the photophobia.
Just to go
That's
back
right.
to the convergence insufficiency, because I'm not sure everyone's aware. So that's really the ability of you to bring your eyes together and focus on a
Correct.
single, if you can,
Target.
yeah, on a single
Yeah.
target.
So that's right. So we use our eyes. Every day, right, to look at certain things in the distance and also at near. When we're looking at things at near, we're using our convergence muscles to do that. And so we take if we can take a pencil or pen and we put it out in front of us. And usually, if you're seeing two images side by side, and you're looking at your pen or pencil, and it's greater than 7 centimeters from your nose to the where you're able to converge, then this can be a convergence insufficiency. And so we measure this in office to give us an idea of how severe someone's convergence insufficiency may be. And we use these muscles a lot more than we may expect our convergence, right? But someone who has had a concussion or TBI, if they're experiencing a convergence insufficiency, their day to day life can really change, right? Because you're not able to converge as you used to. So that, one of your eyes may be going out when you're trying to read, and that causes a lot of problems. And so I have a lot of convergence insufficiency patients, status post TBI.
Yeah, I was the lucky one who had the convergence insufficiency and the fourth nerve palsy. But would
Yeah.
you diagnosed the fourth nerve palsy? It was amazing. It was we were on a Zoom, and you just
Yeah.
asked me to look up and look down, and you said, "Are you seeing double?" And I just looked at you and said, "Like, how could you possibly know that?" And you did. Like, what was it you saw that
Yeah.
told you that
So,
that was going on?
yeah. So, right. So cranial nerve 4 palsies can cause the double vision like you're experiencing. And oftentimes we look at the alignment on someone's eyes. So if one eye is higher and it gets worse in one direction, then we're thinking already from the start, could this be a fourth nerve palsy? And so I'll often take a look at someone's eyes and left gaze, right gaze, up gaze, down gaze, primary gaze to give me an idea if I see a misalignment of the eyes. We do testing in the office. Um, more extensive testing with cross cover and taking a look at, is the eye moving up and down you know, when I'm covering one eye and uncovering the other eye? Is there a misalignment of the eyes that fits with a cranial nerve fourth palsy? So the cranial nerve 4 innervates a specific muscle of the eye that brings the eye down and in. So if that eye is not working, if the eye muscle is not working, then the eye is going to be up and out. And so that's how we take a look at eye muscles in, primary left, right, up and down gaze to give us an idea if someone has a cranial nerve fourth palsy.
Are the cranial fourth nerve palsy and convergence insufficiency two of the most common vision impacts? Are there others?
Yeah, so there are others. Convergence insufficiencies are very, very common. We still see cranial nerve fourth palsies after concussion as well, but we can also see cranial nerve six palsies after concussion too, and that causes the inability of an eye to go out. And so sometimes if someone has a skull fracture, if they have, you know, a severe traumatic brain injury, they can actually injure cranial nerve 6, which has a long course through the subarachnoid space to get into what we call the cavernous sinus. And so this can be injured with patients and can actually cause a problem looking out. So there's lots of eye findings that we can see.
Yeah. How about auditory findings? Because
Yeah.
I didn't start with sound sensitivity, that developed later. So I was just curious about that particular sense.
Yeah. So just like the hypersensitivity that happens to the brain, you get this, hyperacusis that happens. I don't know too much about that aspect of things, but yeah, you're just very sensitive to sounds too. And so I don't know, an ENT might be better to address that one.
So sound, so vision, so
Yeah.
emotion, so mood, so
Yeah.
cognition and memory and balance and dizziness.
Huh?
It's quite a range of impacts from what might
That's
not have
right.
seemed like a big hit. That's
That's
another thing
right.
I'm curious about, right? Is like it I've read this and I've been told this by other people that sometimes people actually have concussion symptoms without realizing they actually even had a concussion. They didn't think they hit themselves that hard.
Yeah. And I see that a lot where they didn't even realize that object hitting their head was even a large impact until, a couple days later they woke up and they were having like this headache that wasn't away and they were feeling nauseous and then they decided to seek care because they were wondering what's going on. And so that can happen where you're like, oh, I'm fine. I'm okay. I don't need to get worked up for this. Go home and then the next couple days you're experiencing a lot of symptoms that you're wondering where this came from. And so that's where the history comes into a big part of that discussion is, do you have the history of the migraines? Do you have history of seizures? Do you have history of any type of inflammation or infection of the brain?
Okay, so I have a weird question that I'm sure you've been asked before because I've come across this and it doesn't make any sense to me, but it seems to be true, which is that once someone has had a concussion, they are likelier to have another concussion. Instinctively, you feel it should be the opposite because once you've had one, you would think you would be more careful. But I can tell you that I have had at least two incidents since, one including walking into an unlabeled glass door. Why would one concussion make someone more predisposed to getting more of them?
Yeah, that's an interesting question because after initial concussion, you may have, like we talked about, dizziness or imbalance. And so sometimes, or you might have double vision, and sometimes that leads you to, you know, walk into something that because of double vision, the visual stimuli coming in at you, you're seeing two things, or you're feeling super dizzy that day. And so fell and hit your head, from the orthostatic hypotension or whatever that may be. But, the concussion that can happen. So, once you've had a concussion, your brain is already hypersensitive. So a smaller impact
Uh-uh.
may affect you more than you thought because of that initial injury to the brain that happened with the initial concussion. And I think it goes along with the associated symptoms that come along with it. And so, kind of just depends on what associated symptoms you had to begin with. But I think that plays a big role.
The vision impacts, the balance impacts. Yes, those
Hmm.
could all lead to that, or just not thinking and just
Yeah.
walking into to a
Yeah.
glass door.
But you're definitely right because, a lot of my concussion patients, they'll tell me that they've had 6, 7 different concussions, and whether or not that was, sports related or not sports related, they know what it feels like after their initial concussion to have another concussion, and so they have really good insight about when they've suffered from another
Mm,
concussion.
it's interesting.
Mhm.
It's interesting. Well, first of all, this has been unbelievable and incredibly educational and helpful. But before we close, we have to do one more thing. So you know about Pesquisistan, and you know that we're governed by a bureaucracy of ministries, right? That cater to the people who, like me, are just not fine and aren't going to be fine, and that's okay. I've been asking every guest, every expert, if they would be willing to run one of these ministries. And the ministry I think you would be perfect for is the ministry of updated expectations, where we stop measuring ourselves by who we used to be and develop new metrics for who we are now. Would you be willing?
Absolutely. Yeah.
Done. I will pencil you in. We have a new minister of updated
Amazing.
expectations. That's the perfect one for you.
Amazing. Yeah, I would love to.
Thank you so much. This, like I said, this has been so great. Thank you for taking the time and sharing your wisdom. I mean, this is just incredibly valuable to everybody.
Yeah, thank you for the invite. I mean, it's been such a pleasure, not only being here, but knowing you and knowing the struggles that have occurred and kind of being part of your team that tries to help you. So
No, and I appreciate it. And I should probably make an appointment to come see you in person while we're both in town.
yeah. Well, thank you again.
Thank you. You've been watching Best Guessistan. In this episode, talking about traumatic brain injury, we featured board certified neurologist and neuro-ophthalmologist Dr. Melody Merati. If this episode resonated with you, or you know someone who could benefit from it, please consider sharing it with them so they may find our community. And to support our work, you can like, share, subscribe, or join us at bestguessistan.com. Until the next time, and remember, in Best Guessistan, there are no wrong answers.